How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melendi, and this is Disruptive Dialogue. Hi, everyone. Chuck Melendi with Disruptive Dialogue. Super excited about today. I've got a good friend, Scott, who is a doctor of pharmacy and a fellow University of Florida Gators.
Go Gators.
Go Gators. That's right, baby. And bourbon drinker.
Hey.
So, as y'all know, supposed to be retired, so have my passion project. I talked to my guests. What would you like to have? Scott and I have had a bourbon in the past when we first met, and I pulled out the Widow Jane, the Vaults, aged 15 years.
And nothing better on noon on a Tuesday.
Noon on a Tuesday.
Cheers.
And I got this, cheers, buddy. And I got this at my 60th birthday not long ago.
All right.
Yeah.
So sharing that stuff.
Scott is going to come here today, and he's going to give us some insights as far as working as a pharmacist in the healthcare industry. As everyone knows, you can't drive a half mile without seeing a CVS or a Walgreens or even these days a Walmart. But Scott works for an independent pharmacy in the state of Florida. And they have a little different experience with the healthcare industry these days than these big chains. I'm going to let you get into why you got into it, but I know that you had family that's been in the pharmacy business. So give me a rundown of what drove you to get into pharmacy and why do you still do it?
Sure. So, growing up, math and science, all that kind of stuff was always my thing. So it wasn't necessarily the biggest artsy guy in the world. It was math and science all the way. But with that, it was, how do I help people? How do I make a difference? I had a family member that was a pharmacist, had his own independent pharmacy, and, see what he was able to do. It was in an area that was a little underserved. And, the difference he made going in there, hanging out there, the relationships he built, that's kind of what I wanted to do.
So that's like when you were growing up?
Growing up, yeah.
So, it's so cool because...
First job at,
Oh my God, really?
14 years old, we're just working in there, just doing random things. But
I bet you hear the bell ring when the person opens the door. Yeah. Well, that's so old school. The small town pharmacy, that was like a rock of the community. And I can see where growing up, you have family members, you go in there, these people come in and, your uncle or your dad or whoever it was, who was the pharmacist, helping them every day and getting to know them and build those relationships. I can see how that would inspire you to want to do this. Fast forward a pharmacy, but an independent pharmacist.
So as a pharmacist,
yes,
you're a pharmacist now. I remember back then, they didn't bill insurance companies. There was no prescription insurance. You came in, paid for the drug, walked out. Very direct. Very, one-on-one business, straightforward, nothing in between. Now, to run a pharmacy, you can't just get a pharmacy degree. You need an MBA. You need a finance degree.
Probably a law degree.
Probably a law degree. Just to understand all the inner workings and how many middlemen and how many people are in the middle. But besides that, you're also, you're more than a pharmacist. You're a social worker. You're, in a small town, you may not have, and I'm lucky to be in an area that's not the case, but in a small town, you might be the only source of healthcare for somebody.
Yeah.
The closest clinic might be 50 miles away. So, the pharmacist might be the source of healthcare information. I also feel like an insurance adjuster now. You also got to be a grocer for that matter and figuring out stock and all that kind of stuff. So.
It's interesting. I don't think, because we all in this country, we live in different cities, towns, environments. And so if you live in a big city, yes, you've got one of the giant conglomerates, the CVS or the Walgreens or whatever on every corner. But to your point, if you're in small town suburbia, you may not have a clinic, like you said, 30, 40 miles away. You may not have a car to get there. Your pharmacist is your healthcare provider to some degree. The independent pharmacy. So just everybody think about not CVS, not Walgreens, not your mail order, But think about you walk into that local independent pharmacy and they've got 6 people behind the desk. You can see them all. They're not hidden behind some big glass thing usually. And they'll talk to you within a minute of walking in the door. There's not a lot of those left. And my understanding is they're disappearing so fast.
Absolutely.
So tell me what's happening.
That's kind of like opening up a can of worms there, but
I'll open up the can if you want me to.
The NCPA, the National Community Pharmacists Association, they do a survey every year. For the survey this year, talking about last year, I think it was 40-something% of pharmacies have reported significantly lower or harder money issues than years prior. And 30% are thinking about closing in the United States this year.
So, well, how many independent pharmacies do you know off the top of your head?
I don't know.
So here's what I do know, because at my old company, we would track pharmacies, is I think we're losing like 1,000 independent pharmacies every year. It may be higher than that.
It's actually I wrote that down.
In the notes?
I do. I wrote that down.
In your note.
Credit to a pharmacist named Ben Jolly.
I got it right there.
Last year, he went and did a whole bunch of research. There were 2,257 pharmacy closures in the United States.
That's crazy.
And 298 changes of ownership. But of that, it was about an even split, 1139 chain and 1136 independent.
And I see this, it says we're losing 5 pharmacies every day.
5 pharmacies a day.
And so for everybody to have like just a grounding of that, as you've heard in prior podcasts, Aetna and CVS are in bed together. Walgreens is the Walgreens Boots Alliance, and they're tied into all these big insurers as well. These giant chains, look, nothing against the pharmacists that are working there. I think you even said you used to work in a chain pharmacy. You don't know any better. You have your job. You're being told what to do. You're understaffed. You're overwhelmed. And it's insane how hard it's like slave freaking labor in these places. I walk in, I feel bad for them, but I walk into independent pharmacies. Now, you're not near me, but at the end of the day, I walk in and they're like, "Hey, Chuck." They know who I am.
Yeah.
And I don't think people realize that those are out there and they're disappearing fast. And my understanding is the reasons they're disappearing fast is that these huge insurers who own these pharmacy benefit managers, who also own these chain pharmacies, how's this not a monopoly and not broken up? I have no idea. But you are just a cog. They are focused on making more money. And they are putting out the independent pharmacies. They're putting them out of business.
Yep.
They are cutting independent pharmacies out of their networks. So if an employer in a town is with an insurer, the independent pharmacy may not be in the network. So all those employers without insurance cannot go to they got to go to the CVS or the Walgreens or the Walmart. This is the one that kills me, is that they can actually pay, if you're in the network, the independent pharmacy, you less than what they pay their own pharmacies to do the same damn thing.
Yep.
That happens all the time, doesn't it? There are drugs that they are telling you that you have to fill to be in their network, that they are paying you less than what you pay to get the drug.
I want to say 30 to 40% of the time, we're losing money on a prescription.
On a prescription. And that's not even paying for the work that you're doing. So the pharmacist is getting a salary. They're spending time filling that prescription, making sure it's the right prescription, talking to the patient, giving the patient advice on how you should take it, how you shouldn't take it. You're not getting paid for any of that. And you're not even getting paid for the full cost of your drug.
So actually, yeah, I think
that's crazy.
The average, I think, in the U.S. for a pharmacy to fill an empty vial, in other words, no cost of goods, is between $10 and $13. So right out of the gate, you need a $10 to $13 profit in order to break even. In most cases, you're losing money per prescription. So the amount of work you do is not directly correlated to the amount of money you make because of the PBM or the pharmacy benefit managers and what they decide they want to pay you, which most of them don't even pay a dispensing fee anymore. Or if it is, it's $1.
So what's a dispensing fee, so everybody?
Oh, sure. A dispensing fee, generally, you've got like a cost of goods, which the pharmacy benefit manager decides what that's going to be based on their own, magical.
And they don't tell you what their cost is.
They don't tell you. Well, they don't have any cost. They didn't pay for it.
Right.
They didn't pay for the drug.
They just wave the wand
and say, this is what it should cost per our magical,
formulas. That we won't tell anybody.
It's proprietary. We're going to pay you this. And then I have to accept whatever that is. Plus, used to be they would pay a dispensing fee. In most cases,
which means that's you just filling the prescription.
Just to cover our costs of filling the prescription.
Yep.
And then here's your total amount that we're going to get paid. And again, in many cases, that's a negative number, and it's certainly not covering even our cost of dispense.
In America, we pride ourselves on small businesses.
Yeah.
They're killing these huge corporations. Are destroying small businesses that are sometimes the pillars of our community when it comes to healthcare. Last year, 2024, United Healthcare, which owns Optum Rx, and we haven't even gotten a mail order yet, made $400 billion. United Health Group, which owns Optum, made $400 billion. And Optum, their PBM, is the most profitable side of their business. Aetna, which some people say Aetna bought CVS. I think CVS bought Aetna. They made like $381 billion last year. And these conglomerates are putting out of business these pillars of our community. This is the fun part that kills me. My understanding is that for you to be in their network, you have to sign a contract. One of the things in some of these contracts is what they call a gag clause.
Mm-hmm.
So explain to everybody what a gag clause is.
First, let me just say that there's big pharma. Then I feel like there's giant pharma. I feel like they're the giant pharma. I heard the top 5 or 6 companies' revenue is 4% of the U.S. GDP. If you break that down, the U.S. GDP is about a quarter of the world's GDP. So these companies' revenue is basically 1% of the world's GDP. So in other words, 1 out of every $100 spent in the entire world is going through these companies.
And these companies only operate in the U.S.
Only operate in the U.S.
They
don't exist anywhere else.
So back to
the gag
clause.
All right.
Because these are things that y'all don't know that we do, and I want to share it with you. So tell them what a gag clause does to you.
The gag clauses are basically, and there's every contract that every single one of them writes is different to a crazy degree. Point that you can't, it's hard to differentiate,
It's by design.
It's by design to be confusing. But the gag clauses, and I will also say that in Florida, I do believe there are some laws about certain gag clause not being allowed.
However, there is, and I'll tell you about it in a second, because that's what I used to do.
You can, go ahead. But so essentially a gag clause is something that basically keeps the patient in the dark about cheaper options, or basically drugs that or alternatives that they could, or like whether a generic, whether a alternative drug. Why wouldn't an insurance company want you to know what the cheaper alternative is? Because that means they're paying less, right? Not necessarily. There are clauses in these contracts that say that I cannot, as a pharmacist, tell you about a cheaper alternative that may be as or more effective than the more expensive product that the PBM makes much more money on.
Yeah. No.
And it may cost you more money as well.
Absolutely. So about 5 years ago, so I want to say, so we're in 2025. So I think it was around 2019 or 2020, the state of Florida passed a law that banned gag clauses of what you're talking about. And so to your point, it was shocking in my role to find out that these large insurer, the CVSs and Optum and Express Scripts of the world, tell pharmacists, you are not, in your contract, you cannot tell a patient, if they go to fill a prescription, that there's a cheaper alternative, that there's a less expensive alternative that's better. Not that you're going to tell them to use it, but to let them know that it's available, that you are literally paying out of pocket more than the cost of the drug.
Yep.
So a drug could cost the insurance company $10. The patient's copay is $25. and you can't tell the patient there's a generic for $1. You weren't allowed to tell them that. So a law was passed that basically said, and this is funny, we weren't able to get the law. When I say we, I'm talking about the lobbyists and all the advocacy organizations that were fighting the insurance companies and PBMs. We weren't able to get the law to say that proactively you could say it. Reactively you could say it. Like, oh my God, this is so expensive. Then you could say there are less expensive.
Can offer it. Yeah.
We had to pass a law. Yeah. And it's not a federal law. It's only a state law. So there are other states in the country, and hopefully there's people listening to this in other states in the country that don't have this law. That literally, I believe that if the law isn't passed and there's a gag clause, you could ask them, is there a cheaper alternative? And they'd probably have to say, I can't tell you. You have to ask your insurance company. I don't know how would that conversation
I believe as long as if they are prompted and asked, they can say it.
But the fact that we're there,
the fact that why do these gag clauses exist?
No, it's just to make more money.
Exactly. Well, and it's not for the patient's benefit.
Hell no. Look, at the end of the day and over time with these podcasts, I'm going to share with people how drug prices actually come about and who makes the decisions. It's all about benefit design, which is done by the insurance companies. But when these insurance companies and PBMs are negotiating with the drug manufacturer, I did that for 8 years. They are making tens of thousands of dollars on some of our drugs.
Yep.
So say there's a $20,000 drug. I can guarantee you these days, the drug manufacturer to be on a formulary costs them money. And then once you're on the formulary, when a physician writes a drug for a patient, to make sure that there's not your competitor, that the insurance company says, before you use their drugs, you have to use this guy's drug, you have to pay them more. So usually it's about 40%, maybe 50%. So right now you have a $20,000 drug that the insurance company is going to make $8,000 to $10,000, say, a year on that drug. Or there could be a generic or a biosimilar, which is a generic of a biologic drug that costs $3,000. And the patient's out of pocket would be for the $3,000 drug might be $50 when they fill it in. Okay. But for the biologic that the PBM or insurance company is making $8,000 to $10,000 a year, the out of pocket is like $200 a fill.
Yep.
They're making you pay that $200 a fill and not the $10 a fill. It's bullshit.
That's once they're in their coverage period, but when they're in their deductible,
they're paying the whole thing.
They're paying the whole thing.
The whole thing. No,
so I see it all the time. There is a generic, essentially a copy of the drug, and the insurance company will require you to fill the brand name drug because they get 40% of $250. When there's a $50 version, you could pay $50 outright, but they're going to make you pay $250 because they aren't paying because they're in their deductible. So the patient's footing that bill.
Yep.
And then they're getting 40% on top of the $250.
And your premium.
And your premiums. It's anti-consumer.
No, I can't imagine as a pharmacist feeling this, knowing this, it's nauseating. So if you were a patient and you come into a pharmacy and they have a very expensive drug, say that the insurance company or the PBM is saying you have to use, they're saying use a brand drug.
Mm-hmm.
If the patient says, I want to use the generic version, can you do that? Or do they have to get approval from their insurance company? Or it depends, obviously.
It depends. In every case, the answer is always it depends.
Could they ask you this, a different question? Could they say to you, is there a generic for this drug?
Absolutely.
So they could ask you, and you could tell them
that's
the price.
A yes or no question.
Right. So what I would recommend to everybody, and tell me if this is wrong, is if you have a super expensive drug, and we're going to talk about mail order in a second because then you lose all control.
Yep.
And you go to the pharmacy and you get the fill and you're like, holy shit, I'm going to pay $1,000 or $500 or $200. Ask the pharmacist, is there a cheaper version, a generic or a biosimilar? The pharmacist can tell you.
Mm-hmm.
And then they would ask you, can I get that? Does my insurance allow? And if they say no, then the patient should not fill that drug. They should call their doctor or the insurance company and say, I want the generic or the biosimilar. And if they say no, go to your HR department and say, our insurance design sucks because I'm having to pay $1,000 when I could get a $30 version that works just as good. Would you agree with all that?
I would agree. And I would actually go further and say, look, when I talk to random people that and say I'm a pharmacist, I just say, oh, you count pills all day. And they don't know who their pharmacist is. You might go to a one of the chain pharmacies where the pharmacist is different every time you go in there. They don't know their pharmacist. They've never talked to their pharmacist. I would encourage you to talk to your pharmacist. Whether it's a question you have, don't go through the phone tree at the doctor's office, just ask. Especially when it comes to drugs and their costs and the price and alternatives. That's actually what they do for a living. That is what we do. I'm happy to have a discussion with you about ways to get you something that you can't afford. Whether it's a patient assistance program, whether it's a cheaper alternative. And once you ask me that question, then those gag clauses come off and I can actually talk to you.
So you know what? Here's a take home for everybody. When you are doing your benefit design, so when you're getting your insurance, and I'm pretty sure even now, if you're already in your insurance coverage, you have that, you can call and you can make sure that independent pharmacies, find out, all you have to do is Google independent pharmacy in my area near me. Find out who it is. Make sure they're in your network. And then change, if you have mail order or if you have in-network, change your pharmacy in your benefit design to that independent pharmacist. Number one, you're going to help them stay in business. Number two, they will talk to you.
Yeah.
And when you go to get your drug, don't go there right after work when then you got to hit the grocery store and then got to go make dinner. This is a really important moment. Make sure you got 30 minutes to go in there, whether it's an independent pharmacist or a chain, so you can take the time to ask a couple questions. So you can say, is this the least expensive alternative of the drug that, you don't want one that's different, but a similar drug or generic or a biosimilar. Is there less expensive options? Am I covered to do that? How could I get that? Leave yourself time to talk to the pharmacist to fully understand it. That is a huge investment in what you are going to pay out of pocket every month moving forward. The difference between paying $20 a month or $150 a month, that's worth 30 minutes.
Yeah.
That's a real, when you
times 12.
Times 12. When you go in there to get your drug, make sure you have the time to do it. Do not be in a rush. It is super important. And that little bit of time starts to make a difference. Starts to make a difference in the whole chain of what's going on, how much money they're making, how much control they have. Get out of having to always go to CVS and Walgreens. You need to start to go to these independent pharmacies. That is the only way we're going to get any kind of power back. So we talked about gag clauses. Give me another thing that these large corporations do to independent pharmacies that hurt them.
Oh gosh, where do I start?
Well, give me the biggest one.
I mean, in fairness, though, I will just go back and say that still have plenty of friends and colleagues in the chains. I'm not going to tell you that they don't do a great job, and they aren't there for you as well.
Absolutely,
and they can do all of those things. Unfortunately, they are burdened with so many miscellaneous tasks and optimized by the non-pharmacy, MBAs and bean counters up top that says that you're only allowed this number of this amount of help and you have to do all these extra services and you have to make this many phone calls a day and all this kind of stuff that unfortunately, in some cases they are overworked. They may not have the smile on their face that you're expecting when you do talk to them, but they are there to help. Many of them do a great job.
And Scotty, thanks for saying that, because look, at the end of the day, and I've said this I've worked with PBMs and insurers and hospitals, and don't hate the player, hate the game. Yep. These are good people busting their tail, trying to do the right thing, but they are think about if you're at a job and your boss tells you, okay, do not spend more than 2 minutes with that patient. You need to fill this many prescriptions per hour. You need to do this many things you don't have a choice. That is your job. And if that's the first job you had, that's all you know. Metrics
should not be in healthcare, but
no, it's not.
That's another.
So many things in healthcare right now. That's all good. So we talked about gag clause. And look, shout out to the chain pharmacists, not your C-suite people, the chain pharmacists.
And pharmacy staff.
And pharmacy staff, y'all are doing a Herculean job and doing a phenomenal job with the time that you are given. And props out to you. Thanks for making sure that we said that. So it's interesting because this is when I used to start negotiating. I started negotiating with health plans around 2010. Mm-hmm. And back then, this is, I covered on this earlier, but back then we used to tell them, this is crazy. We used to tell them we would negotiate with them for drugs to be on their formulary, et cetera. We said, we'll give you 1% to 3% for your administrative fees as long as all the drugs are equal access. No preferred, no keeping anybody off formulary. Everybody did that. They finally broke one company down. One of the companies broke, and then all the rebates and fees, and then they grew and they're huge and they're giants. But when I would go and talk to people about this, they go, wait a minute, you work for the largest drug company in the world, J&J. Just tell them to screw off. I'm like, we can't. United, Aetna, and Cigna, who are with the 3 biggest PBMs, have 85% of the U.S. market. If we say no to one of them, we lose 1/3 of our business overnight. Same with you. And what you just said, people don't always equate pharmacists like physicians, that you have a relationship as a healthcare provider. Y'all have relationships with these people. You know them. They're in your community. And to say no to an insurer that has 1/3 of the country, so 1/3 of basically your constituents, you have to tell them no. Mm-hmm. And you're friends with them and you take care of them and you're part of their healthcare team. That sucks. And that should not be allowed.
You might have grown up with them. That might be your first grade teacher. That's yeah. And so those big corporations doing this affects everybody. And then when the pharmacy decides to, take it because they have no other option and get reimbursed under cost, well, all of a sudden that pharmacy ceases to exist. That's one of the 5 pharmacies a day that close.
5 a day. So, what's interesting is, I talk to people, there are laws that are trying to get passed. But we're trying to eat the elephant one bite at a time. And I think we need an elephant gun and just kill the elephant right away. I will say one of the strongest, best PBM bills was passed in the state of Florida 2 years ago. I think you know where I'm going. And my understanding, because I was part of this, the dynamics where that was at a great employer in the state of Florida, Publix, who has their own pharmacies, got pissed off that the big insurers who had their own PBMs were starting to cut them out of the networks. And so Publix, being a very valuable employer in the state of Florida, said, okay, enough, and went to Tallahassee, and other independent pharmacies joined them, and all the medical societies joined them, and the employer coalitions joined them, because everybody is getting hurt by these insurers and these big PBMs. And a law was passed, and Governor DeSantis signed off on it. And it was a pretty solid PBM bill that basically said, you know what? You cannot cut out pharmacies from your network. Everybody was so excited. And then their suits found a loophole. And the loophole was that only applies to new contracts. Mm-hmm. So my understanding is they just stopped writing new contracts. So there's no new contracts in the last 2 years with these insurers and PBMs in the state of Florida, because if they do, then they have to follow the law. But if they just keep the old contracts, then they don't have to follow the law. Is that?
Yeah.
That's what's happened.
Well, among other things.
Literally, that's like laughing at our state legislator and our governor right now.
I can, sure. I can't tell you can't go there, but I can tell you can't go there. I can say, well, for the first 2 fills, you can fill it at whatever pharmacy you want. Then you have to go to our own pharmacy or through mail order. I do have people that come in and, and maybe this is Florida, but mail order may be in a different state and different state laws. I don't even know. I'm not a lawyer. I don't know how that works. But I have people all the time that they've been coming to our pharmacy for, God knows how long. And then you come in one day and you say, they covered it this time, but they're not going to next time. You have to go to mail order.
So they don't get to talk to a pharmacist.
They don't get to talk to a pharmacist. Wait on hold. Wait 2 weeks for your meds. Or the other way around it is, sure, you can go there, but we have control over the price you pay there. You can go there and pay some obscene amount of money, or you can go to our pharmacy
And pay $3.
And pay significantly less. So they made the decision for you that way. Sure, they may not be able to tell you, I mean...
Right, they don't have to tell it to you.
They don't have to
tell it to your pocketbook.
Sure, absolutely. And of course, unfortunately, every day I have to tell people that come in and say, can you, my prescriptions need to go over here. All I say is, I understand.
So that sucks. I'm glad I'm giving you a little bit of bourbon today.
Yeah.
So mail order.
Yep.
I don't know a ton about mail order. What I do know, and I read stuff and I'm trying to research it more and more and more, is, how it has been packaged. And I will tell you that my mom gets mail order because she doesn't have a car and it's convenient. Although the more I read, I'm like, holy shit, this is not a good thing for me to be doing. Mm-hmm. And I know that mail order is a huge, huge profit driver. Not only does it eliminate a pharmacist, so that's why all these chain pharmacies are closing because they're going more and more mail order. But I hear they're doing crazy stuff.
Crazy things. There are a million shenanigans they play. It is convenient for certain people. And you know Absolutely. What? If you're on very common drugs that never change, it may work for you. And that's great. If you don't have a lot of specific needs and it works for some people. But when you have that specific need, when that specific need arises, they're not there for you.
There's no one to advise you.
They have optimized that so much. You're waiting 30 minutes on hold to talk to somebody. You're waiting 2 weeks to get your drug. Especially, let's say you have a what they call a specialty drug.
Specialty drug, absolutely.
Which a drug that they force you to fill with them because they that's where all the money is. They don't allow you to fill that at a retail pharmacy.
Right.
So why do they even care about how happy you are with their service?
It doesn't matter.
It doesn't matter because you have no other option. So they will put you through the ringer because you have no other option.
Yeah, they can do whatever they want.
They can do whatever they want.
Yeah,
while making lots and lots of money.
Yeah, those are, we used to call them closed networks or specialty drug networks. And for your biologics or your specialty medications that require certain refrigeration, certain handling, certain things like that, drug manufacturers will work with specialty pharmacies because they want to be able to control the handling of that drug, but it doesn't cost them anything extra. They actually want to be in those networks. But my understanding, I'm starting to find out because I'm working with a benefit consultant, is that they're charging everybody more money, saying, well, we're in a specialty network. It costs more. No, it doesn't. That's bullshit. So give me if you were a patient and you want to navigate the system from your point of view, what's one key thing that people can do? What's something that you would say, if I was a patient, this is what I make sure I do?
Talk to the pharmacist. Simple.
But which pharmacist?
Well, I mean, whoever your pharmacist is that you trust.
If you don't have a choice.
If you don't have a choice, I mean, but talk to your pharmacist.
That's a great idea.
I mean, it's that simple. Somebody that understands what your options are and, hey, there are things that the pharmacist doesn't know in terms of how your plan design works and all that kind of stuff. But at least that's a starting point. After, you can say, hey, there's these 3 other drugs that would be very similar to that drug and significantly cheaper. And then you can talk to the doctor.
Yep.
Or, and you know what, here's where the chains and the independents will kind of differ. An independent pharmacy might say, I'll call the doctor and see if the chain's going to say, you call your doctor.
Or you go see your doctor.
You go see your doctor. But, that's at least a stepping point.
Right.
And then they can say, hey, you know what? It is what it is. You don't have any way around it. Or, oh, here are your options. And then from there, you might have to call your insurance company. Hey, fight with your insurance company.
Right.
Hey, call the doctor and see if they can do this. Or see if this is an option and go from there. I mean, I think it's as simple as utilize the knowledge that a pharmacist has.
And I think it's a great point and a simple point. And we said it earlier, but when you're going to go to the pharmacy to get your drug, make sure you're not pressed for time because they're stressed out. They got a lot on their plate. They're doing the best that they can. And it's a very important decision and cut them slack. Don't get upset with a pharmacist, especially the chain pharmacists. they're under so much strain and pressure, and they're doing the best that they can. So I think that is a great piece of advice. So that's on a micro level.
On a micro level.
On a macro level.
On a macro level.
What do we, as citizens of the United States of America, who are getting pummeled daily by these giant corporations that are making so much money right now and doing a shitty job, and we're getting poor healthcare outcomes, what do you feel that we can do or should do to try and change the system?
Sounds so simple, but speak up. Talk to your legislators. Push for transparency. That is the number one thing, is why do gag clauses exist? To hide and not be transparent. Push for transparency. I think a lot of things would change. I had a couple that worked for a major airline, and their insurance renewed at their company, and they both get specialty drugs. That year, they decided that it was going to be must go through mail order.
The insurance company.
The plan design.
Sure.
Insurance company mandated their drugs be mail order. So they come to fill it on whatever date, and I break the news to them because they weren't aware. And I break the news to them that, no, it's now giving me a rejection that says mail order only. Why don't you give them a call, see what's going on? They actually spoke up to the HR of the major airline.
Good job.
And I will give them all the credit in the world, and then kudos to them to change their plan to allow people to get their specialty meds at a retail pharmacy, just based on speaking up. And, and they came in, and basically their thing was, I don't trust anybody else with my medications except for this pharmacy. I will not use another pharmacy. And they got that, they got that done. So speaking up can make a big difference. And that was for a major airline, that was a company-wide thing that they changed just by two people speaking up.
Dude, I just got chills because people don't realize the power that we have, and people don't know how the system. So our insurance benefit designs, if you work for an employer, your HR department is usually the one that is making that contract. Mm-hmm. And what people don't realize is you're always going to your physician or to your pharmacist or the insurance company, but who you really should go to, and God, that's such a great example. You go to your employer, your work, your HR department, and go, this is bullshit. We pay premiums. We pay them a lot of money. I don't want it this way. You need to call the insurance company as a giant employer and say, this is not how we want it. We want it a different way. And to your point, two people go to their employer and change everything for everybody in that corporation.
Yep.
This is what we all need to start doing. That is such a great example. What a great story.
Yeah.
And kudos to those people.
And I mean, it was an honor that somebody, felt that I was worthy of that fight. And so, but it is an amazing story, and it shows that it can change.
Brother, it was a pleasure.
Yes.
Enjoy the bourbon.
All
Everybody,
right.
I want to say thanks to Scott.
Yeah.
Support your independent pharmacist, Anthony Chacha at 3 Axis Advisors. He is an independent pharmacist, has a phenomenal podcast. The PBMs and insurers hate him so much they have a smear campaign on him right now. But support your independent pharmacist.
Yeah.
Push back. Talk to your pharmacist. Ask questions. You can make a difference. Thank you. Take care.